Just waiting for the confirmation.
Yep.
Yeah, I think we are on, Dr. Irgau.
Great.
All right, well, good afternoon again. This is Kemal Erkan. I'm the chairman of American Surgery Center. We have not done our live event for the last couple of weeks with our scheduling challenges, but Dr. Ingall is here today with me. Dr. Ingall, welcome back. How are you doing?
Thank you, Kemal. It's great to be back on Bariatric Friday.
Well, it's good to have you again. So we are going to continue our sessions at 3 p.m. from now on, just to kind of help the scheduling from your side and our side. And we also have, we changed our medical ACO to 2 p.m. and we did our first session today. We're hoping that it is, it's our goal. I mean, you and I, we do like doing these events, and we want to make sure that we can keep it on the weekly schedule. That's our goal. But of course, you and I, we both have full-time jobs. So far, this doesn't pay for us. And then with those challenges, we do actually have some difficulties, but that's not a problem. So we are back. Well, since it's been a couple of weeks, Dr. Irgau, so you can actually maybe introduce yourself, and then we'll start with the sessions after that.
Absolutely. As I said, it's great to be back, Kemal. One of the reasons, and I appreciate this very much for you pushing this session a little bit later than usual, is because, as you know, I operate in the morning at the hospital, and because the office doesn't want to let patients wait too long, of course, they schedule them, and then I have to take care of them. And so 3 o'clock actually works great. So it's great to be back. As I said, my name is Dr. Irgau. I am the president of CHRIAS, or Christiana Institute of Advanced Surgery. My specialty is bariatric surgery or weight loss surgery, and I have been performing weight loss surgery now for 20 years. And with my associates, we are by far the most experienced group providing weight loss surgery in our area, not only in the state of Delaware, but also in the counties surrounding us from the other states. And I enjoy very much doing Bariatric Friday. My patients certainly tell me that they watch them and they learn a lot. And I'm very much hoping we would continue doing them.
These days we are getting a lot of feedback for these videos, and I didn't realize that it was that people were watching. So if you miss one, I get a message from either from the office or from a couple of the followers, and it's good to have that demand there. So I would like to also introduce our other surgeons in the program as usual. So Dr. Irgau as head of our practice and program, and we have in our team, we have other surgeons who are also bariatric surgeon. Dr. Gail Wynn, one of the most experienced female surgeons in the United States in bariatric and general surgery, most likely. And Dr. Mike Peters, Dr. Rose Singh, and Dr. George Ibrahim on the bariatric side. We also have a colorectal surgeon who's one of our partners, Dr. Sachin Maid, and all operating at American Surgery Center and working together for our patients. From the dietitian side, nutritionist side, we have Fran, Amy, and Beth, who are working with our patients directly to prep them for their surgery and even after the surgery. And this is, they're part of our team, and we are so happy to have them. Now, CHRIAS altogether has done more than 10,000 surgeries. So when it's a surgical practice or surgical, any surgical procedures, what makes you better is number of surgeries you have done as a surgeon and as a facility, and that becomes your specialty after a certain point. And CHRIAS is the brand name for surgery, not only just for bariatric, but for general surgery and minimally invasive surgeries as well. Yep. So we have these videos that we are recording, and we are also putting them on our YouTube accounts and sharing with our patients. Most of those patients who are in the program, they're watching these, and we would like them to watch them so that it does help them to understand what needs to be done before and after in a better way. So we want to discuss the issue of dropout from the program. Now, Dr. Guy, I may be a little bit biased for this, but you and I, we worked so hard to have our own place so where we can actually, where we don't have any more excuses for things that are not being done. So we work with the different hospital systems, and we knew that the bariatric is our core specialty. That's our main specialty, and when the interest is not there, certain things did not happen. And one of the things is that having case conferences more frequently, and there were reasons for these. The reason we wanted to reach out to the patients or keep in touch with them is because it's a difficult process that they are going through. But now with the surgery center, I'm pleased to say that we don't have these issues, these excuses. And what's most rewarding is we do see the numbers and the ratios. Like right now, we are at 27% for both last year and this year drop rates. It is much higher in the industry. And then that's almost 100%. The reason is because of our approach in the patient care and the prepping the patients for that process. Now, you are, as a surgeon, not only you do actually perform surgeries, but you also lead our case conferences, and you are our go-to person with those. So if you can just maybe explain our process a little bit, and then we can discuss what are the reasons that patients are dropping.
Absolutely, absolutely. So bariatric surgery, as we've said in many other sessions, is by far the most effective treatment we have for the treatment of morbid obesity or clinically severe obesity currently. So, and that is defined as a weight that it is at least 100 pounds higher than the healthy or ideal body weight. And with this in mind, the reason bariatric surgery has gathered wide acceptance right now, Kemal, is not only because of its effectiveness, but also because of its safety profile, right? It has become a safe surgery comparable to surgeries like gallbladder surgery or hip replacement surgery, right? That was not the case 20, 30 years ago. And the reason it has become this safe is because the preparation process is much more rigorous than it used to be. In places like ours, where you are a center of excellence, so you're certified by national bodies that you have high quality rates, it means that your preparation has to follow those rigorous processes as well to assure that safety. Now, the process can be long, of course, and the process can be fairly complex as well, right? Because when patients come to us requesting bariatric surgery, we see them in consultation, but then we have to send them to different specialists to start what we call the multidisciplinary preparation and education that includes several visits with nutritionists. It includes a visit with the psychologist. It may include preparation and visits with a cardiologist, maybe with a pulmonary specialist. It may include upper endoscopy, which is a procedure we do to evaluate the inside of the digestive system before the surgery. That requires a lot of navigation, and our center is probably one of the best in the country in terms of helping patients navigate this, because as you correctly said, Kemal, we hold case conferences on a daily basis, reviewing and seeing where patients are. And that's why we have such high rates of follow-up and such low rates of dropout when you compare to other programs. Nevertheless, there is a dropout rate. So what happens to patients? Well, First of all, patients come to require bariatric surgeries at different levels of understanding and consciousness, I would say, right? For instance, typical person would be somebody who has heard about bariatric surgery a number of years before coming for consultation. Mm-hmm. And their first reaction when they hear about it is that it's not for them. They reject it outright. But then the idea matures in their head as they learn more about it, but also as they continue to see how they are struggling with their weight. They try different diets, and year after year, they resolve to do it by themselves, and yet they find themselves in the same situation, if not in a worse situation, because the weight continues to go up. As they go up in the years, it becomes harder and harder. So it takes a number of years before they make that decision. But there may be patients who come a little bit earlier and they are exposed to bariatric surgery a little bit less. So the motivation itself could be variable when patients come to ask for consultation. And if the motivation is different, it means also that when there is a cumbersome and complicated appearing process, patients may not follow up as easily, right? And that's where we see the dropout rate. Now, there could be situations in which patients may find themselves really rethinking and saying, maybe I'm not ready, maybe I have to wait. And patients do tell that to our coordinators. Sometimes we ask the coordinators, and they tell us, hey, this patient has decided to hold off on bariatric surgery. It could be for personal reasons, but it could be because they want to try one more time to do it by themselves. And those reasons are obviously valid. But what we don't want to happen, obviously, is for patients to drop out because they cannot get through the process. And that's where we want to be at our best, and we are, obviously. And recently, you told me how you instituted this process of sending reminder emails to our patients in a fairly seamless fashion to remind them about tasks that they need to accomplish. One of the ones that you talk about very often, for instance, is doing blood work in a timely fashion. So blood work needs to be done as part of the evaluation when we start the process. But the reason we want to do blood work is because we want to make sure there is not something that requires correction. If the blood work is done too late in the process, then if something needs to be corrected, that would obviously delay the process. So we want the patients to do the blood work early in the process so that we can address issues like an elevated hemoglobin A1C, which is a sign of diabetes, or an abnormal level of hemoglobin or abnormal level of thyroid function test, all things that require really fixing and adjusting so that patients are prepared optimally. So when you send emails to remind patients in a seamless fashion, this helps us greatly. It really simplifies the process, not only for the program, but also for the patient. So with all that preparation, obviously, if patients are following us, the chances for them dropping out is going to be obviously less. But having said that, sometimes perceptions about bariatric surgery, perceptions and guilty feelings about why they're not doing it by themselves and they're relying on bariatric surgery could be all influences that could come up to get patients out of the program. Now, this has to do also with how our society views bariatric surgery in a way. Some sections of our society still look at bariatric surgery as a cop-out, as an easy way out. Nothing could be more untrue than that, right? Because bariatric surgery is an extremely important and serious and necessary treatment, but perceptions persist. And part of the reason we do all these sessions is obviously to try to change those perceptions.
So, Dr. Irgau, this is one of our letters that we are sending to the patients, and this is I call this like our next level patient communication. Clearly, the patients will be able to see who their care coordinator is. So this is one of our test patients, but we assign this to our practice administrator, Melza Dimak. So it's interesting enough that when you see what's coming out of these, like the way that you are hearing them probably from our patients, they receive these. So maybe it's my competitiveness in a way that like when I see them, when I send a letter, because these are happening on our case conferences, and sometimes I do send them, I personally send them because it's so easy now, but you send something and then 5 days later, patient completes the blood work. So that's really actually rewarding from the case management standpoint. So the truth is these patients do need help more than anyone because the process is difficult. In fact, when I wrote about the process of bariatric a couple of years ago, one of the main issues for us was how patients are gonna go through all those problems and not get frustrated through the system, through the steps that they have to take. So, and then we took this to a different level for our patients. So, and what that is that everyone has a case care manager from our team. So every patient has an assigned person, and they talk to that person throughout the process. Now, I was just looking at some of the data from bariatric numbers. So 54% of the patients are dropping after they start the process. Now, and I promise you that I won't go into too much technical stuff, but when the numbers are good, so I do like to brag about them a little bit. So this is our numbers. So from the process that we are going through, how many of these patients are going through? Like in 2019, it was 32%, but the last 2 years we are down to 2.
Are you sharing the screen, Kemal? Because I don't see it.
I thought I was sharing, but apparently I'm not.
Okay.
I feel like I always share the screen. So
okay, there it is. There it is.
I'm not sharing. It's so rare. So here's what I was. Thank you. So actually, I knew something was wrong because I was trying to see the drawing function and I couldn't find it. So now this is our 2019, where the drop ratio was at 32%. Like the industry right now is at 54%. So we are at 27% last 2 years. I mean, this year and the last year. So the completion rate. Now, of course, the 2021 is not done yet because we have a lot of patients in progress, but 71% completion rate is a big achievement from our point, and we are extremely happy that we are able to reach out to our patients. So now, going back to the letters that we have, so when many patients are still in the process of getting these, and I was just trying to get a couple more examples of it, but let me just see if I can find one more. So it should be right here. So they are, so we have our survey letters, and let me see one more second. Dr. Earlier we were talking about like on the bariatric, on the United Medical ACO side, how we are actually utilizing these letters. Yep. And we have about 8 letters now that actually is in place. So, and even on that side, we get so many responses in a short amount of time. I think the patients are also appreciating this less complicated communication. So because in some cases it's a lot, like they have to go through, open the portal, they get the message saying that you have a message, but then they don't actually know what they got. And, we are all a little bit lazy, including us in some cases. So how we can actually keep in touch with them and not to make them feel like they're by themselves is only if we are able to constantly communicate with the patients directly. So the formats of these letters are pretty much the same. Now, Dr. The other thing that I wanted you to kind of go over some of the main reasons that patients are dropping out. So someone who, and that one of the things that I always tell you, I'm all on the data and statistics and look at the numbers, and patient comes back again And then that's the returning consult. And the first thing I look at it is the BMI that was in the initial one. And I haven't seen any patients who didn't gain weight since the first initial consult, and then they didn't complete, and then they come back. Every returning patient is heavier than they were before. And this is real. This is actual numbers. Now, knowing that patients are not going to be able to get out of the morbid obesity problem on their own, there are some miracles, but the surgery is for the group of patients that we are discussing. This is the surgery is maybe the only option 97% of the time. So why would someone not go through that process and delay it, and then as you delay it, it becomes a bigger problem?
Absolutely. So that is really an issue of really understanding the seriousness of the problem, but also what the problem really is. As we very often say, from our point of view as healthcare providers, obesity is not an appearance issue only. It's not a convenience issue only, right? Obviously, those things matter, right? The way you feel when you have so much weight, and that obviously is very important. The way it interferes with your daily chores and it affects your the quality of life. Those are important things. But primarily from our point of view, we know and understand that morbid obesity is a devastating disease. It is the center of many, many illnesses that affect many, many people, whether it's diabetes, whether it's high blood pressure, sleep apnea, heartburn, many other health problems are related to obesity. From that point of view, it is our duty, obviously, to make sure we offer this treatment, right? But also we know it's not something that we can mandate people. We have to educate them. We have to make them understand, right? And that is the key very often. And that, our society doesn't do enough of that. There is not enough awareness of how important it is to take care of morbid obesity, because as you correctly say, obesity, when it is left alone, does not stay the same. It gets worse. It gets worse. When you leave it alone, it does not get, it doesn't even stay where it was. It gets worse. So it is not surprising that a patient who started our program about a year ago, and then they, for a number of reasons, they drop out, they don't continue, but they come back to seek our help again, invariably the weight is much higher than what it was the first time we saw them. So they may have developed even illnesses that they were not aware of, when we saw them the first time. So it is critical for us to make sure they understand this and that they go through with the process. But why would they not? Obviously, it has to do with many things like the perception also that I was saying earlier on. The perception is that, and that may be among their friends, among their communities, the idea would be, well, if you are heavy, it's your fault. Therefore, you should take care of it yourself. You shouldn't find somebody else to take care of it. But that's looking at obesity from a very, very misunderstood way, not understanding that a person is obese because their biology is pushing them towards that situation. Not surprisingly, when people try to lose weight, they find it very hard, and yet the weight gain is much easier. So our own body, our own biology treats losing weight and gaining weight in two completely different parameters, right? You can gain weight very, very easily, but try to lose weight, obviously it's a lot harder, right? So with that situation, with that biology, and living in a society where we are, where there is plenty of calories around, where food is so pervasive, and also our life is so much automated that the opportunity for us to be active physically is so much less, then the result is not surprising. In obesity is the result. And so we look at communities, year after year, and we see the average body mass index increasing year after year. And for the individual person, it's not different. If obesity is left alone, years pass, and that will be worse. There will be more weight, there will be more pounds, and the BMI will be at higher numbers as well, essentially. So it is a question really of making sure people understand this. Now, there is something to be said about the fact that the process is complicated, as you say, right? Now, there are certain things that we know have to happen because we also understand that bariatric surgery is not a magic answer. It's a tool, it's a powerful tool. And part of the preparation before surgery is really making sure patients understand that, in that if they want to remain healthy for the rest of their life after bariatric surgery, if they want to stay thin, it is critical for them to make sure they change their way of living as well. And part of the educational process we have through nutrition and encounters with the surgeons is also really to make sure that happens, that it's not a magic answer, right? But some hurdles that are placed, particularly by some insurance companies, there's no data to support them, right? The fact that they say, oh, you have to go and see a dietitian for 6 months, month after month, without missing a month. It's almost like a punishment, right? It's almost as if these patients have to show that they have earned the right for this treatment. It is actually crazy. You don't ask for that when you're treating cancer. You don't ask for that when you're treating an infection. And yet, when you're treating obesity, the patient has to demonstrate that they are going to go to appointments every month for 6 months. And if they miss 1 month because something happened in their life, then they have to restart the whole process again. This type of attitude actually discourages people from seeking treatment as opposed to encouraging.
It's interesting that, when we say that patient has to earn to get the surgery, this was the title of my article for the access to care challenges. So the discrimination is what we use, the term that we use, and that is definitely what's happening.
Yeah,
so but because changing that may be a lot more difficult, we find a different solution, right? So we have a team that takes care of our patients. Now, one of the dropout reasons, I believe, is some patients do have smoking habits. Some may have others. For those, what kind of support we can provide so that they know that going into this, we don't lose them from the beginning?
Absolutely. So that comes from the fact, obviously, that we ask all our patients to stop smoking. Those patients who have this habit to stop smoking, before surgery, that's an important requirement. Now, it's easier said than done. Obviously, it's very, very hard for patients. So we really actually address this issue from the get-go, at the beginning, right? We have a frank discussion with patients that this is really something that we cannot compromise on. We cannot negotiate on, really, because there are certain dangers associated with continuing smoking and having the surgery and having had bariatric surgery and having the habit of smoking. And of course, we provide different means, including the approach to their primary care doctor, where they could have even medications to help them do that, but also to provide them with programs and literature that will help them do that. And we follow them through, right? We talk to them through about that. And it's not unusual for a patient to come and tell me, look, doctor, I want to do it. I'm going to quit. And then they quit that week. And then maybe when I see them 2 months later for follow-up, something happened in their life and they say, well, I picked up a cigarette again. Well, it's not a punishment. It's not something where we're going to say to them, okay, you've done this, so you're out of the program. Absolutely not. What we do is we understand these things can happen. We re-engage with them, right? And we tell them, well, we're going to try again. We're going to start over again. We're going to try to provide you the means for stopping smoking again, and then re-engage in that way. So it's not a question of just saying to the patient, okay, go stop smoking and then come back when you have done. It's really for us understanding that this is a process where we have to partner with them in order to really help them. Now, the outcome of that is obviously fantastic. If one of the most satisfying things I have as a surgeon, Kemal, is to see a patient of mine who used to be morbidly obese and a smoker, and a year to 2 years later, they are not only non-smokers, but also a lot thinner and a whole lot healthier. This is a total transformation that gives enormous satisfaction when you're a bariatric surgeon.
So that actually, like what you said earlier, with the way that we work with the patient, we are not stopping the process, because we know that at least 3 months, up to 6-7 months we have in front of us. So we work with the patients instead of just saying that, okay, well, go and get this taken care of and discriminate. We work with different team members from our side, They are in touch with the patients. We bring them more often to get that initial support. And like even for simple stuff, we do need this support. And like you remember, like the way that we do the intermittent diet, you and I, if one of us is doing it, the other one is not there. It just doesn't work sometimes. So I feel like I'm more reliable if I know that you are doing it. Yeah. So versus like if you are by yourself. So
right.
I think there's a lot of good outcome that we see. Just look at from the dropout ratio standpoint, like 54% to 27%. What we have, that is extremely satisfying. So we do actually see these not just from the dropout, but as many people know by now, that our patient satisfaction scores are the highest in this industry. So we are at 99.4%. For facility to be at that level is not common, and we are seeing the results, and our patients are happy. And like they name these care team members, our nurses, and even from the business office to the PACU, patients are part of. They are actually taking this service at the best level, and then they do show this to us because we send them personal letters, and we ask them how they are doing. We prep them, and they are happy at the end of the day. So that's the most important part. Now, again, Dr. anything else you wanted to mention with the dropouts?
No, I think, we definitely are doing way better, and obviously than, the average that we see around the country. But obviously we want to do better. We want to continue educating our patients, make them understand that bariatric surgery is an important form of treatment. And as their caregivers, we will work with them so that they get that treatment.
And you and I, we are 100% committed to our patients, and our team is they work long hours to reach out to our patients. So the commitment is there from our point, and I'm so happy to see the results of it. And we'll be back again next week, 3 p.m. for the Bariatric Friday. Thank you for being with us, Dr. Irgau. Thank you for coming back.
So thank you, Kemal. Thank you. It's great to be here.
It's always a lot of fun to discuss these with you, and we'll see you guys soon. Bye-bye.
Okay.